Good evening, everyone. On behalf of the Scleral Lens Education Society in Glaukos, we'd like to thank everyone for joining us this evening and welcome you to a webinar focused on keratoconus, scleral lens considerations, management, and FDA-approved cross-linking intervention. My name is Dr. Drew Biondo. I'm the Scleral Lens Education Society the Remote Education Committee Chairman for the Scleral Lens Education Society. Ahead of the start of our program, I want to pass along a few pieces of relevant information. We want to ensure your questions are answered, and we have enabled the Q&A function, which can be found at the bottom of your Zoom screen. Please feel free to submit your questions at any time during the webinar, and we will aim to answer them at the end of the presentation. Because we're using that Q&A function, the chat function is disabled. Please note this webinar is being recorded so that we can make this information more accessible following the conclusion of our program. I'm pleased to introduce our speaker this evening. Joining us is Dr. Gloria Chu. She completed her Bachelor of Arts and Doctor of Optometry degrees from the University of California, Berkeley. Following completion of a residency in cornea and contact lenses at Southern California College of Optometry, Dr. Chu pursued further fellowship training in prosthetic replacement of the ocular surface ecosystem, or PROS treatment, the Boston Foundation for Sight. Dr. Chu developed and supervises the USC PROS service and is actively conducting research in the areas of irregular cornea and ocular surface disease. She's an active member of the Scleral Lens Education Society and a leader in the field of keratoconus diagnosis and management. So without further ado, I'd like to turn it over to Dr. Gloria Chu.
Thank you so much, Drew, for that very kind introduction. And I just want to thank everyone for being here this evening. I am streaming live from Los Angeles from my office. First of all, I just want to thank Glaukos for just supporting optometry and supporting optometric education like this. And also want to give a huge thank you to the Scleral Lens Education Society, to every single present and past board member. You guys do so much behind the scenes, and you've developed this amazing organization that not only aims to educate patients in the community, but contact lens practitioners just like us. And in this very exciting and amazing field of scleral lenses that is constantly evolving. So thank you for all that you do, including hosting webinars like this for our community. So thank you to all of you. So without further ado, the topic for tonight is keratoconus. We're going to be talking about scleral lens considerations, management, and the FDA-approved cross-linking intervention. These are my financial disclosures. And here are indications and important safety information that we're going to be covering a lot of during this talk. And this is a disclaimer that the following information is not treatment advice for any particular patient. We as optometrists need to use our own clinical judgment for each individual patient. So let's start with an overview. So keratoconus, as most of us probably know already, is a corneal disorder with central thinning and steepening. It's a bilateral condition, but often asymmetric. So in the photos on the right, you can see the top two images where a patient is really not so much affected in his right eye. He sees very well uncorrected without any lens or glasses. In his left eye, however, you see pretty significant central scarring. The photos on the bottom demonstrate a patient who has mild to moderate central scarring that's pretty symmetrical. It's a progressive condition, meaning that most people, I don't know of any who are born with keratoconus, but develop it at some point in their life. It does progress for a certain amount of time. We don't know to what degree or for how long, but it's our job to catch it when it starts and hopefully prevent it from getting worse. It's a non-inflammatory condition, meaning it's generally not associated with keratitis, neo, and dry eye, although you can develop dry eye. The onset is generally during the teens or puberty when the hormones are changing. And the prevalence and incidence varies widely depending on where the patient is from, the ethnicity, and also the study. Now, one important thing I want to stress is that the diagnosis of keratoconus is often made by us, optometrists. We as primary eye care providers see the most patients, much more than our ophthalmology colleagues. So for instance, if we're seeing 10 patients a day, 50 a week, and 200 a month, if the prevalence is 1 to 2%, we could be seeing 2 to 4 new patients and diagnosing this condition in a month, and hundreds over our career. And I love this table here because it shows various studies and the prevalence that they found in their particular study in all different countries. It ranges from close to 0 to almost 5% in this study from Saudi Arabia. So again, even if the prevalence is only 1 to 2%, we could be detecting 2 to 4 new cases a month in a general practice. I know many of us here are probably in specialty practices where we see many more keratoconus patients, but even for our general optometric colleagues, we are catching this at a much higher rate than some of our other colleagues in the medical field. So in this graph on the right, this is from a study published last year based on a study from Denmark. They actually showed that the present incidence rate based on data from 2011 to 2015 has increased 2 to 3-fold in the last 10 to 15 years. This is possibly due to more complete data due to cross-linking being available in the early 2000s, which may have changed referral patterns and also improved diagnostic equipment. So we all know that there is a genetic influence. It can be autosomal dominant or recessive. I have many family members. I have fathers and daughters and mothers and sons and those with siblings and aunts and uncles that have keratoconus. So make sure to ask about this. The environment may play a role in etiology as well. UV exposure from maybe where they live geographically, atopic or skin conditions, and contact lens wear that could potentially be irritating the surface and leading to more inflammation and progression. There are risk factors including family history, age. So younger patients are going to be at higher risk for developing this early and more severely. And eye rubbing. Eye rubbing can release inflammatory mediators that can then lead to progression of the disease. So in our times now, we actually have genetic testing. A company called Avellino has genetic testing, their universal genetic tests that screens for 5 types of corneal dystrophies. Now, within the last year, they came out with a newer AvaGen test that screens not only for corneal dystrophies, but also for keratoconus itself. This is done with a non-invasive cheek swab, maybe like some of the COVID tests that we've done in the past 6 to 8 months. And this company also offers genetic counseling for patients who test positive for certain conditions. So this has been out only within the last year, and it's something to consider for maybe your patients who are really concerned about this disease, or maybe even for some who are considering LASIK, in which keratoconus is a clear contraindication for LASIK. So let's kind of walk through how we make this diagnosis of keratoconus. So here I am doing retinoscopy. Most of us do this with our patients. Now in keratoconus patients, even if you don't have a topographer or a tomographer, when you do your retinoscopy and the cornea is irregular, you may see a scissoring pattern, not a clear with or against the rule, but the bars coming together. That's a clue that you could have keratoconus. When you're refracting your patients, if you're seeing an otherwise healthy patient that you cannot refract to 20/20, or you're getting very strange astigmatism and their responses are very inconsistent, another clue that you could be suspecting an irregular cornea. Then finally, we're using our slit lamp and looking for signs of keratoconus. So you're looking for central thinning, you're looking for central striae, iron deposits. As seen in this picture, you can see a nice brown ring, which is the Fleischer's ring, where iron deposits at the base of the cone. And then if you have equipment such as a topographer or a tomographer, it's very, very helpful to document changes and monitoring these patients over time. And one thing I want to point out when we go talk about our equipment here, so many people first wonder what's the difference between a topographer and a tomographer. So a corneal topographer gives you 2D imaging and maps the front surface of the cornea. A tomographer, however, gives you 3D imaging. It maps the front and back surface of the cornea and also gives you cornea thickness data, which I love. Now, one very important piece of information that comes from tomography that you can't get with topography is the elevation of the posterior cornea. So I'm just going to go back to this really quick. In the bottom right colored graph, you have information on the posterior cornea. And it's been demonstrated in the literature that early cones often demonstrate elevation on the posterior cornea, even before the front of the cornea. So if you're suspecting something, or if they have a strong family history, you might consider sending them for a tomography. We also have anterior segment OCT now, which was initially used for retinal conditions, but now is used for so many corneal conditions, including scleral lens fitting. So many of us here might have anterior segment OCTs, which we use to see if the lens is vaulting over the limbus or how much the lens is settling into the conjunctiva. In my practice, I typically don't use takes so long to do the imaging, but we'll go over some other tips as to how to judge your fits. So we're going to start our first poll question. Which would you recommend first for a patient with progressive keratoconus? iLink FDA approved cross-linking only, your contact lens fitting only, or a corneal transplantation. So this is when you're seeing a patient, you know they have progressive keratoconus. What is the first thing you are going to recommend for your patient? It is a tricky question. I had a patient that I had to make this decision for just a few weeks ago, so I'm really interested to see what you are all going to share in this response. So I'm just going to give you a few more seconds. All right, let's take a look at the answers here. All right, can we take a look at the answers for our first poll question? Okay, so 74% chose iLink FDA approved cross-linking first. And I think this is a great mentality because that means that you understand the importance of catching this early and preventing possible progression. However, the other group who said contact lens fitting, I completely see where you're coming from. Your patient's coming to you to see better. They walk out with nothing to help them see better. How is that going to make them happy? I think if you educate your patient that this disease is progressive and we want to help to maintain and preserve their vision and prevent developing complications that can develop in advanced keratoconus, they'll understand. So in the patient who I saw 2 weeks ago, he was a mild cone who had clear progression. He had come in for a scleral lens consultation and was wearing soft toric lenses. I had a discussion with both him and his mother, who was in the room, that I recommended doing the FDA approved cross-linking first, because if progression were to happen, we wouldn't be able to go back on that. However, if he could tolerate wearing soft toric lenses for just a little bit longer, we could get him into scleral lenses that clearly gave him better comfort and vision after the cross-linking. Thank you so much for that. I'm going to close the poll and move on to the next slide here. So, as mentioned, patients come to you because they want to see better, because this condition severely distorts their vision. So one, we can prescribe glasses. In mild cones, some of them can see still 20/20 and very well, sometimes with high amounts of astigmatism, but they work. We now have so many great contact lens options. So I wanted to show you this picture on the right. So the picture of these glasses here are from a keratoconus patient of mine who somehow got a prescription for -20 in each eye and filled it online and got these glasses with clip-on sunglasses for, I think, $25, including the case. But as you would expect, they didn't work very well and we're coming back for better visual correction. So in terms of contact lenses, we have many options and they're continuing to grow on almost a monthly basis. So for our mild cones, we can start with spherical and toric soft lenses. There are also custom toric and soft lenses that work very well for mild and moderate keratoconus patients. We have hybrid lenses with a soft skirt, a rigid center. RGP lenses, here's an example of an RGP that's been working really well for this patient. A piggyback modality where you have an RGP on top of a soft lens. Sometimes you use that soft lens like training wheels. And then we have scleral lenses. And in the last 10 years, I'm truly amazed at how far we've come. We have image guided and impression options now. Profilometry is becoming more available with instruments that allow us to get really precise measurements of the curves on the cornea. And there are companies now that even make lenses to conform to the exact curves of the sclera, which is quite amazing. So now your patient, you fit them with scleral lenses. Is that the end of the story? Is everyone going to be happy now? Well, I think they're going to be happier, but it's not necessarily easier to fit a patient into a scleral lens compared to some of the other lens options. Our pros include generally better comfort, no rubbing on the cornea. You can oftentimes get abrasions with RGPs, less lens dislocation and loss. I had a patient come in recently who said, I just dropped my lens down the drain, I need a new one. Or some who are outside, they look too far to the right and it pops right off. Well, that generally doesn't happen with scleral lenses. We have much more stability, not only in the fit, but also vision. However, this is where we get into cons. As we've learned over the last couple of years, there are a lot of complications associated with scleral lens wear. If you're converting a patient from an RGP to a scleral, you need to be aware that the true corneal shape emerges eventually over the course of several weeks or months. This may change their prescription and may possibly change the fit a little bit. They will have difficulty with their glasses. They're going to have spectacle blur. If they could wear glasses with RGPs before, I've had some patients say to me, you know, now I can't wear glasses at all. They just don't work. And I hear this complaint a lot. You know, you fit me with scleral lenses and I see so clearly, but I feel like my vision actually got worse without my contacts. Now, I don't think their vision actually got worse. I think one, they got used to having super sharp vision in their sclerals, and now they just notice just the huge disparity without having the lenses. Now, you also run into potentially all kinds of tear film issues with clouding, debris, which solutions to use. And I've had a few cases where I have been bit and I tried to convert RGP patients to sclerals, and I struggled with clouding despite changing the diameter, the toricity. I just couldn't get rid of this clouding and had to end up back into RGP lenses, and that was okay. The patient at least knew that we tried another option and that they were happier in their RGPs, and that's perfectly fine. And with scleral lenses, you get some strange complications that sometimes you don't even know how they develop. These pictures on the bottom, this patient only had these lenses for 6 months, but he had such dry eyes. I don't know how he developed these crazy plaques, but we had to end up ordering new lenses for him. The images on the top show patient with Fuchs dystrophy, as well as intacs, with central changes, who's done fantastic in scleral lenses for over 3 years now. So aside from vision, your patients are going to ask you, doctor, are my eyes getting worse? So this is very important. We as their doctor need to follow up and monitor their eye health. We need to follow up with them every 6 to 12 months and even sooner in younger patients. I had a patient, a young 20-year-old patient that I asked to come back in 3 months to repeat corneal mapping just so I could keep a close eye on him. So when we monitor, what are we looking at? Well, we need to do manifest refractions. As tedious as that is, it gives us a good idea of how their vision is changing. Looking at best corrected vision in glasses and contacts. Looking at corneal thickness. Are they thinning over time? Look at the profile with mapping and also their lid health. Many patients have allergies, so don't forget to treat their ocular allergies with topical medications if necessary. And also many keratoconus patients also have floppy eyelid syndrome. I've asked several times if they have floppy eyelids, do you snore? Do you have sleep apnea? Some of them know about it, some of them don't know about it, and then I refer them for sleep testing or to consider a CPAP machine. So one important tip here is to make sure to take the scleral lens off during an examination. Sometimes if your contacts are fitting so well, that could be masking progression, and the patient really won't know because they're happy and comfortable with their with their contacts. So this is a little bit, some of the tips and what I do in my practice in terms of testing in my scleral lens patients. When they come in, I always test vision with their incoming contacts. I don't care if it's cloudy, if there's mucus, I want to know what they walked in with. I also look at the lens on their eye. I want to see, is it impinging? Is mucus getting under? Do they have bubbles? Do they have an eyelash? Do they have cat hair underneath their lens? I want to see what's going on before that lens is removed. I physically remove the lens, put a drop on the small plunger, I remove it, and the ease of removal gives me a clue as to whether the lens is fitting well or maybe it's too tight. I always stain with fluorescein. So when the lens comes off, I see if it's leaving any impression mark around the eye. Look at the cornea, the conjunctiva, and measure the eye pressure. As many of you may be aware, there's been a lot of controversy about whether scleral lenses may affect IOP over time. So it's important to monitor that in your patient so we can make sure we're not causing harm in our patients with scleral lens wear that tends to be resting around where the drainage system of the eye is. After all of that, then I do imaging if necessary, and then I do a refraction. Then I rinse the lens really well and put the lens back on, and that's when I actually do the over refraction because I get more accurate results once I've cleaned it and rinsed their eye. Then you have to decide in evaluating this patient's scleral lens, is the fit acceptable? If yes, continue wear and return to clinic either in 6 to 12 months. I have some patients who've been wearing their same scleral lenses for 1, 2, 3, or 4 years. And if there isn't a problem, if it's not chipped or cracked, it's in good condition, there's no reason why they can't wear it. If not, then you're gonna reorder or refit them. Aside from the lens, you need to decide, is their ocular health stable? If yes, don't forget to tell them that their keratoconus is stable. They want to know that, and they feel confident knowing that they're staying, stable in your hands. If not, educate the patient, treat, or refer out if necessary. In terms of visits, this is typically what I do. For a new patient, I will see them first for their consultation. And for those of you who don't take insurance, you can bill whatever you want, and I think that's awesome. But in my practice, I do take a combination of PPOs, HMOs, vision insurances, Medicare. So I have to know what insurance I'm using. Typically, the first visit is a medical consultation with me, and I decide what the best type of visual treatment is for them. Then, depending on their insurance, you do prior authorizations or you fit them with the lens, and it often can take 2 to 5 or sometimes more visits. So be prepared for chair time with these patients. Follow-ups. Once you finish their training and finish their fitting, you may need to see them in the beginning, maybe 3 to 6 months. Once they're stable, you might be able to go to annual visits. Again, for younger and high-risk patients, it's very important that you see them more frequently. So goals for our keratoconus patients. You want to ultimately have good vision, good comfort, and good ocular health. We want to protect vision, monitor corneal changes, and prevent progression and ultimately avoid corneal transplantation. There was a study published just a few months ago in the Canadian Journal of Ophthalmology that looked at the survival rate of penetrating keratoplasties. They looked at a database of over millions of people over from 2011 to 2017, filtered out almost 600 patients with primary penetrating keratoplasties, and found that the 7-year survival rate was 73%. That means close to 1 in 4 could fail within 7 years. And I know traditionally we've heard that corneal transplants are, very, very successful surgery with I typically hear 90% success rate, but this study that just came out this year indicates potentially that success rate could be a little bit lower. So if we can prevent our patients from getting to that advanced point, it's going to be much better for them and us. So what are some procedures that can help to improve vision in our keratoconus patients? Well, one is corneal intacs. This was FDA approved for keratoconus in 2004. And the aim is really to flatten the cornea. We also have topography guided PRK, which the aim is to smooth the cornea. It's kind of like a touch up. We're going to go over these in more detail. And the last resort is really a corneal transplantation. And this is reserved for patients in which the scarring and thinning is so advanced that they cannot function with their specialty contact lenses anymore. So in terms of intact and scleral lenses, the goal really is to try and improve uncorrected and spectacle corrected vision. Now, best corrected vision with scleral lenses, if they go back into a scleral lens, may actually not improve. Also, be very careful of patients who have large pupils. When patients come to me with intacts, I always get a little bit nervous because they come in saying, I had a very successful procedure with my doctor. He said it went great. My cornea is flatter. So now can you just fit me in glasses or contacts? One thing I hear often is glare at nighttime and glare driving. Because of the intact segment and the size of their pupil at night, sometimes no matter what you do, they're going to have glare at night. And there's really not much a contact lens can do to fix that. Maybe with some higher order aberration correction, it might help a little bit, but still there's a segment of plastic in their eye. Now, you need to warn patients, if you're referring for this, that they often will still need visual correction after the procedure. Now, talking about topography guided PRK, this is a procedure that can be done after intacts and cross-linking once you've stabilized the cornea. The goal is to smooth out the cornea and create a more symmetrical curvature and potentially improve refractive outcomes. So this is not PRK, which is photorefractive keratectomy that you would do in a -8 myope. You're not going to remove very much tissue at all. Sometimes you're only removing maybe 45 microns. However, this may potentially allow for transition from specialty contacts to sclerals, moving from sclerals to potentially standard soft contacts or soft toric lenses. So if it can smooth out the cornea just enough that you can refract better and get a toric soft lens, that may help your patient a lot. Some of the challenges, though, include epithelial healing and corneal opacification. Now, with corneal transplants, I have had so many patients, I don't know why, within the last couple months say, Doc, can I just have a corneal transplant so that it can fix my condition and I can see better? It's so important to educate them that a transplant is not refractive surgery. They're not going to walk out of there seeing 20/20 like they had LASIK. It's only indicated to remove scarred and abnormal tissue where you cannot correct their vision anymore in a contact. And it's hard for them sometimes to realize that because they think with surgery, I'm going to come out just seeing better. Even if it's a little better, I'm going to be happier. But I've seen so many patients after the transplant with similar vision uncorrected. Although the scarring is removed, It can improve contact lens corrected vision after, but uncorrected vision is generally not great. However, there are a few patients I've seen who have 20/25 vision uncorrected, and I think that's amazing. So it's possible. Now, for some of your patients in scleral who have had corneal transplants and require scleral lenses, here are a few tips. Make sure to monitor their best corrected vision. Check for haze and edema or hypoxic issues or changes or growth in peripheral neovascularization. So for corneal thickness, you can use pachymetry, which you can bill for, or tomography to look at the corneal thickness, which you can also bill for as a tomography. Consider your highest DK lens materials. Why not? We have such great plastics now, close to 200 DK. Put your patients with grafts in higher DK materials. And also make sure that you're completely vaulting the cornea after settling in the conjunctiva. We don't want to be rubbing against the graft. So ultimately, we want to ensure that the lens is not inducing edema or contributing to graft failure. So your patients are going to say, doctor, is there anything I can do to help my keratoconus? Well, yes, there is. We have corneal cross-linking now, which aims to slow or halt progression of keratoconus. The Glaukos iLink cross-linking procedure was FDA approved in April of 2016. You know, it sounds like it was just so recent. It's been done in Europe now for decades, but I feel like in the US, we're just late to the game. The iLink procedure involves the specific KXL system and the Photrexa viscous and Photrexa drug formulations. Indications are only for progressive keratoconus and corneal ectasia following refractive surgery, like LASIK. The procedure involves removal of the epithelium. So this is an epi-off procedure. It takes about an hour where you're dropping riboflavin for the first 30 minutes at about every 2 minutes. And then you need to ensure that you have an intraoperative corneal thickness of a minimum of 400 microns. And this is important to help protect the endothelium. Once you've confirmed that you have at least 400 microns of thickness, you then expose the cornea for 30 minutes to UVA light. And through this process, the activated riboflavin and reactive oxygen species interact to form these crosslinks and stiffen the cornea. So let's take our second poll question. What is most important to consider when referring a patient for cross-linking? So if we could get that poll question up for the audience to choose their answers. The choices are proven procedural safety and efficacy, insurance coverage and cost to the patient, and patient satisfaction and positive word of mouth. So what is the most important thing to consider when referring your patient for cross-linking? Proven procedural safety and efficacy, insurance coverage and cost that they have to end up paying, or patient satisfaction and positive word of mouth. So let's take a look at the answers here. All right, so 84% of you consider proven procedural safety and efficacy to be the most important. And I think I am speaking to the right group of people here tonight. Second most important is insurance coverage and cost, and that's also important. And of course, patient satisfaction. I think this was slightly a trick question because I think really all of these things are important. So one important thing to know, which we'll go over in a little bit, is with the iLink FDA approved protocol, you can have a much greater chance of achieving all of these things. So let's move to the next slide. So now I'm going to walk you through kind of a visual of this procedure. So the first thing you do is debride the central approximately 9 millimeters, generally with alcohol, to remove the epithelium. You then put drops for about 30 minutes with Photrexa viscous. You then check for flare. This is to ensure that the entire corneal tissue has been saturated with the drug. Once flare is observed, then you check with a pachymetry to make sure that you have a minimum intraoperative thickness of 400 microns. So this means that when referring your patients, if they have 400 microns, that's excellent. But even if they're slightly thinner than that, I have, from what I understand, you can get a swelling effect from maybe about 50 to 70 microns, but I would check with your surgeon. It may vary per patient, but even if you're a little bit less than 400 microns, they may still be a candidate for the iLink cross-linking. So if you're not at that thickness, you're gonna put the Photrexa until you get to that thickness. It's a hypotonic solution that swells the cornea. Then once you reach that point, you irradiate for 30 minutes. So again, this is the KXL system. It's FDA approved cross-linking. No other riboflavin solutions or UV devices can be used in the US outside of a formal study. In terms of the age, there are actually no specific age range limitations. However, patients from 14 to 65 were included in the FDA study. So it's kind of unknown what happens in the other age ranges. It's not advised during pregnancy, and just some complications that you should be aware of and may occur include ulcerative keratitis, corneal haze, scarring, dry eye, epidefects, pain, light sensitivity, and potentially reduced vision if they have scarring. So this is what our procedure room looks like at USC. These are my corneal surgeons. This is the bag where the riboflavin comes from, the machine. Dr. Nguyen is holding the machine. And these days we do everything with masks on, and we actually do test our patients for COVID prior to their cross-linking. In terms of setting expectations, we need to educate our patients that cross-linking is aimed to slow the progression, but this is not refractive surgery. So if they expect to have the procedure and come out seeing 20/20, we didn't educate them properly. This will not remove any scarring or striae that they have already. And it's helpful to often treat the dry eye before the procedure to enhance their healing. Also let them know that after the procedure, they will still likely need visual correction, whether it's in the form of glasses, soft contacts, or scleral lenses. So what's the recovery period like? They will need a bandaged contact lens for about the first week. There may be discomfort. Don't rub your eye. And to make sure to call your doctor if you have sudden pain or vision decline, because it's important that the epithelium heals after the procedure. So let's do our last poll question. When would you start a contact lens fitting after cross-linking? So let's see the question. And the answers, the choices are 1 week post-op, 1 month post-op, 2 months post-op, and 6 months post-op. So when would you start a contact lens fitting after the cross-linking procedure? 1 week, 1 month, 2 months, or 6 months after? So let's take a look at the answers. All right, so 1 month. So it's almost, we tied for 1 month and 2 months, and that's exactly what I would say. For patients, it varies depending on the healing and also when you can get them in their office, but I think you are spot on. It's really between 1 to 2 months. 6 months, it's possible if maybe they were having delayed healing or their vision is fluctuating, but most patients want to get into lenses sooner than that. And with global periods that are often 3 to 6 months, sometimes you can start a fitting and expect to make some changes over the next few months before you finalize the fit. So again, post-operative considerations. After the procedure, your patient will likely be on a topical antibiotic and steroid, sometimes a non-steroidal anti-inflammatory drug, lots of lubrication to keep it wet, and have a bandaged contact lens, usually for a couple days or up to a week. It's important to remind them not to rub their eyes to displace the lens that could affect the healing process. 1 week is generally when you remove the bandaged lens and when you see the epithelium healed. At 1 month, this is when you assess the vision, do corneal imaging, and consider a contact lens fitting. But sometimes it could be 2 months because the stroma does remodel. And if you're not getting kind of consistent readings, you might want to wait a few more weeks. You want to continue to follow at 3, 6, and 12 months. Their glasses prescription may change, and I'll share a case that will go over that in just a few minutes, and also continue to do topography or tomography to see if the cornea is stable and potentially flattening. One important thing for all of you to know is that there's no global period for this cross-linking procedure. So that means every time you're seeing a patient, you can bill your follow-ups to their medical insurance. I love these photos. This is a patient of mine who had cross-linking. She was post-LASIK ectasia that was continuing to progress. And you can see before cross-linking are the top 2 images. The bottom 2 images show changes in the structure of the stroma 2 months after the cross-linking procedure. So clearly something is going on, and you see this demarcation line that is often used to show if the procedure was effective or not. Potential complications include infections, non-healing epithelium, corneal haze, scarring. Sometimes the haze, I do have to mention that it can fade over several months, so it may not be permanent. Potential endothelial cell damage if maybe the cornea wasn't thick enough. Remember, you need 400 microns intraoperatively. And also, rarely, continued progression. I've had some patients have to have the procedure twice. Now, as I mentioned earlier, cross-linking is not a new therapy. Even though it was only approved in 2016, it's been around for almost 2 decades in Europe. I show these papers because one that was published in the American Journal of Ophthalmology in 2003 says that collagen cross-linking may be a new way to stop progression of ectasia in patients with keratoconus. That was almost 20 years ago. So we need to really be on top of catching these early patients and referring them for cross-linking so that we can help to halt and slow the progression. Some very exciting news is that Glaukos completed enrollment in their phase 3 Epi-on cross-linking clinical trial last year. So they used many centers here, and they're looking at 275 eyes. What they're doing is using a new UV light source, supplemental oxygen with goggles, a new drug to help penetrate through the corneal epithelium without having to do an epi-off protocol, and potentially reducing the treatment time from 1 hour to about 20 minutes. So this is very exciting, and I can't wait to see the results. I want to briefly mention that topography and tomography can be challenging, especially when they tend to get more advanced. When you're doing imaging, whether you or your tech are doing it, make sure to optimize their tear film, work with the blinking, lid, fixation errors, because you could get very inaccurate K readings that could guide you or not guide you properly if you're not getting good, reliable data. So try to repeat it until you get reliable data. These images were of the same eye, seconds apart. Clearly, the one on the right is a lot more accurate. So let's go over a case here. So I have to share this picture. I love it so much. This is a patient of one of my eldest patients, one of my wisest patients. He's in his 90s. I started seeing him when he was in his 80s. Look at how thin his cornea is. And he has done well in scleral lenses for many, many years. So it's possible. So here's a 25-year-old Caucasian male. We saw him in February of 2018, where he had worsening blur in his right eye more than his left. His incoming uncorrected vision was 2100 and 2040. We could not refract him properly, and we were able to demonstrate that he had progression. We cross-linked him 2 months later. Now, I saw him about a month after, but still struggled a bit with the manifest refraction. However, we did start a scleral lens fitting. He achieved great vision, 20/20 vision in each eye a couple months later. So these were his pre-cross-linking maps. So you can see in both eyes, you see the classic inferior steepening and thinning inferiorly. Now, it's important to note that usually a month or two after the cross-linking, as the stroma is remodeling, you may see a little bit of steepening. And this is what we saw with him. He had about 55, 45 pre-cross-linking in the right eye. And about a month or two later, he was 56 and 46. We're like, oh my gosh, did he get worse? Well, these were his tomography maps, and we're able to kind of show the profile of his corneas. And then we saw him back 5 months later. And what do we note? The corneas have now flattened. So while they did steepen a little bit a month or two after, as the stroma is still changing, it did eventually flatten again. And typically we do expect a flattening effect, and maybe more in the more advanced eyes. In this case, more of a flattening effect in the right eye compared to the left. I love anterior segment OCT imaging because it really just shows how beautifully you have this ectasia and thinning in these corneas. So I just saw this patient back in May, right when we kind of opened up after the COVID lockdown, and we did tomography mapping again. His corneas remained stable. In the right eye, we're about 54, 45, left eye 47 and 44. And compared to the pre-cross-linking Ks, you can see that we did achieve a flattening effect, and his corneas have been stable for 2 years. These are his eyes. These are the scleral lenses that he is wearing now very happily. And here's a picture of the central corneal striae that you oftentimes observe in these patients. Now, again, just reflecting on some of the data findings back a couple months ago, 2 years after his cross-linking, he's getting 20/20 vision in his scleral lenses. His autorefractor is still wacky. So don't expect the autorefractor to give you any consistent, helpful readings. However, look at this. His uncorrected vision improved to 20/40 in the right eye and 20/25 in the left. Compared with 2 years prior, his incoming uncorrected vision was 2100 and 20/40. I was finally able to refract him with a reasonable amount of astigmatism, and he was refractable to 20/40 and 20/20, unlike his incoming values. So this isn't what will happen in every patient, but this is one patient of mine that I saw that ended up with great success. In advanced keratoconus, we want to be careful because they can develop complications such as corneal hydrops. This patient presented in the middle of our COVID lockdown, called saying they woke up with a white cornea, and I knew it was hydrops. I eventually saw the patient just a few months ago, and here you can see the break in Descemet's membrane. So we want to ultimately prevent patients from getting so advanced that they have challenges and complications like corneal hydrops. And I just want to share this case. I know we talked about genetics in the family. Well, here's a mother and son pair. I actually started seeing the son first. He struggled with hybrid lenses, so I fit him into scleral lenses about 3 years ago. And then he said, you know what? My mom's really been struggling with her RGP lenses. I'm going to send her over to you. So now I see both of them, never at the same time. I don't know if they just never hang out or what, but always at different times. And they're both wearing scleral lenses very comfortably now. So this is just a reminder that there's definitely a genetic influence. Unfortunately, the son was much more advanced than his mother. However, he does have a 5-year-old daughter now. So I have stressed the importance of early eye exams, telling the doctor that there's family history of keratoconus, make sure they're not rubbing their eyes, and to get topographies or tomographies done early for her. So ultimately, it's much better to refer for a second opinion or for cross-linking than to have to refer for a corneal transplant. You know, there was a study published just last year by the American Academy of Ophthalmology that looked at keratoconus natural progression. It was a systematic review and meta-analysis that looked at over 11,000 eyes. What they found was that young patients, especially those less than 17, and those who presented with K max steeper than 55 diopters, we're much more likely to progress. So in your young patients, especially those in their teenage years, or those who present with high K readings already, especially 55, they're going to have a much greater risk of progression. So keep a close eye on those patients. You might even see them back in 1 or 2 months if necessary. So again, we want to preserve vision, we want to slow progression, and protect against the need for surgical intervention where you can have complications such as graft rejection, higher cost, infection, and severe ectasia, again, as seen in this graph. I'm just going to move actually past this because we've already talked a lot of these things, talked about these already. And I want to get to this slide here. This is very exciting. In early 2017, believe it or not, there were only 3 insurance plans that covered cross-linking. Today, we have 6 national and 62 regional health plans that cover cross-linking for our patients. Remember, this is for the iLink FDA approved cross-linking. So if offices are doing off-label procedures, there will not be insurance coverage. So one other important reason why we want to consider the FDA approved protocol. So ultimately, we want to refer for FDA approved cross-linking because of these 3 C's. We can have confidence knowing that this procedure has been rigorously tested through FDA trials, that there is coverage from most major insurance carriers now. So maybe they were denied a year ago or 2 years ago, but they're still a candidate. They haven't quite progressed. Try to get them cross-linking again. Maybe you'll be covered now. And last is knowing that you are being conscientious and recommending a procedure that you know has been tested for safety and efficacy and that has been proven to have good results. An important thing is to know over the next couple of months before December 30th, there is a Living with Keratoconus patient support program where your patients can receive up to $100 towards their non-reimbursable copay expenses. So just another maybe reason to encourage your patients to have it done sooner rather than later. And I want you all to take note of this website, livingwithkc.com. This is a fantastic website that has resources for patients as well as providers about where to find cross-linking experts who are offering iLink, the FDA approved version of cross-linking. And I'm going to quickly mention this iDetect Keratoconus program. Many of you may not have heard of this yet, but Glaukos and Topcon are partnering to offer you advanced topography technology at a lower cost of entry. So for those of you who are managing keratoconus patients or want to manage keratoconus patients and don't have a topographer yet, this may be a great program to allow you to get one at a more affordable price. As part of this iDetect program, you're invited to participate in a scientific data registry where you may upload data from potential keratoconus patients or post-op iLink patients. And if you want to learn more, I encourage you to email idetectkc@glaukos.com. In conclusion, scleral lenses are a great option for keratoconus vision correction, as I think everyone here tonight knows. A few tips: make sure to remove the lenses on examination because vision and comfort could be masking progression. Refract regularly. Make sure to get your K readings. You can even get them from an autorefractor sometimes. And perform topography and tomography. Even with advances in the technology that we have today, there was actually a study published just this year in Contact Lens and Anterior Eye from clinics in Belgium that showed that we are still diagnosing keratoconus too late, often in the moderate stages, when we should and could have been catching it earlier. So in addition to technology, we need to be using our clinical judgment, what we're seeing in the exam room and from our other tests to help guide our diagnosis and treatment. I want to share one story. I know we have questions to get to, but I just want to share this one story. I saw a patient on Monday and I took over his care from a previous doctor who had done a great job monitoring the corneal presentation, documenting no scars, no striae, and also doing tomography mapping. I reviewed maps from 2017 to 2019 from the other office and found that the left eye was stable, but the right eye, I saw 1 diopter of progression in the Kmax. And maybe it was just, oh, maybe the tomographer was off, maybe it wasn't in the left. So let's just continue to monitor. I saw him back on Monday, a year later. Unfortunately, now I started to note mild scars in the right eye. We did tomography again, and now he had advanced another 2 diopters. I sent him immediately for cross-linking. I helped him to understand that there was progression going on in his right eye and that we wanted to do our best to slow the progression. So I hope he gets cross-linked in the next couple of weeks, and then I'm going to refit him into contacts after. So just another reminder that we need to watch these patients carefully sooner than every year. If they're young, this patient was in his 20s, and we don't want to see progression like this happen.